Meeting is being recorded.
Good afternoon, everyone. My name is Katie Cook from Adirondack Health Institute. Welcome to the March Telehealth Learning Collaborative. I guess this is one of those few meetings that isn't being canceled because it's virtual. So I thank you all for being on the line today. We have a bit of a packed agenda. I know the agenda that I sent out about a week and a half ago was a little condensed, but with the onset of the COVID-19 pandemic, I'm going to spend a good amount of time after Michelle and Katie speak going over some of the changes that are occurring from a telehealth perspective. It's our goal to provide as much education as possible to all of you, and it is literally changing by the hour right now. So we have a significant update to provide all of you. And just as a friendly reminder, please mute your lines. I'm still hearing some of you with some feedback, so I would really appreciate it if you would be courteous to everyone on the call and mute your line. Any questions that you need to submit can be submitted through the chat box for our speakers, and I will go over ways to submit questions regarding COVID-19 later on in the webinar. So I'm going to turn the reins over to Michelle Hager. Michelle is from Blue Cirrus Consulting. She's a managing partner there, and she is going to speak to us about telehealth program maturity. Age does not define maturity. She's going to go over the maturity model, which will help your organizations assess pre, post, and current effectiveness of your telehealth service lines. So, Michelle, your line's unmuted and you can start.
6102.
Good morning.
0
Can you hear me okay?
1
I can, but
0
somebody's
is not available.
Hold on.
At the tone, please record your message. When you've finished recording, you may hang up or press 1 for more options.
Okay, I think I muted the culprit here. Go ahead, Michelle. You're good.
Okay, no problem. Listen, I know that it is I really appreciate you being here today, especially under these circumstances. There's a lot going on, so really appreciate being here, and I will try to give you as much information as I can in as short amount of time as I can, and hopefully help folks to move their telehealth programs along. Obviously for us, this is a key for everyone, and for the TRCs obviously as well, to just be able to proliferate information and be able to move people's programs along. Okay, so that being said, there are 3 factors really in having a mature program, and you can imagine they're not far off from what we see in some of the other models, AAA, et cetera, but people, processes, and technology are a key factor in a mature program. And so I'm going to talk and touch on several of those. Obviously, with a limited amount of time, I won't be able to touch on all the elements of the maturity model that I'll show you in just a moment. But these 3 areas are places where I think are key. And also from the technology perspective, what we see over and over and over again is too much weight put on the 3rd factor there, and the technology factor. Less on people and processes, and what ends up happening is we have a tremendous amount of investment happening on the technology side, obviously given the opportunities that are out there from the grants that are received from USDA and others through the RUST grant process. But we need to incorporate at least all 3 of these, and in our process you'll see there's actually several other areas that you really need to look at in order to make sure it's a program that's mature.
Real quick, Michelle, for everyone on the line, I don't want to have to ask you again to mute your lines. I'm going through and muting people, but please put yourself on mute. There's a lot of feedback. Thank you. Go ahead, Michelle.
No problem. So this is our maturity model. We have this copyrighted. It's actually a model that we worked on a couple of years ago as we looked at it and have refined over the years, and looked at sort of what are the key factors in driving people towards maturity in the telehealth space. So I'll leave all the detail for you to kind of pour over on your own, but I will talk about a few things. One thing is we developed this so that it would be very familiar to folks. So this is based partly on what you see from the MRAM models, from HIMSS for EMR adoption rates. So you see the stages that are kind of up on the left-hand side. And then we also looked at some of the other models that are coming from organizations and are typically used to seeing those, things like Gartner models, et cetera. So one of the areas that we felt like was important was, well, several of the areas was the governance of that program, the vision and strategy that was developed for the organization related to telehealth, the people, and have we trained those people? Do we have just a siloed person who is doing telehealth and no one else understands how to do telehealth? Do we have, you know, a good technology platform that's unified and integrated across, or do we really just have something that's point to point? And then clinical, do we see these things being driven in order to achieve population health metrics, and also do they have solid clinical workflows behind them? Many times that we work with organizations, we find that it's the workflow that causes folks to fall down heavily in that area. They haven't defined the workflow, they haven't defined outcomes, and therefore the programs end up being less than successful and a lot of times turned off, or folks find other ways to do the work. I'll give you a good example of an organization we're working with right now. I won't call them out because, you know, we're trying to work through them, but they have a heavy investment in the carts, typical carts that you would purchase from a, you know, with a high-profile vendor, and those carts are delivered in all locations, both where the patients would be and then also where the physicians would be. So you can quickly see that obviously the carts need to be located where the patients are, to be able to demonstrate and view certain areas, you know, using a horoscope, et cetera, to be able to view appropriately to the patient. However, we don't need the complex carts with peripherals at the physician location because they're obviously going to be the recipient of the visual. So we've had a double investment in this organization, which is a tremendous amount of money. Over to almost $3 million invested in this organization in these cart systems, which actually are not going to be, probably about half of them are not going to be functional. So things like that, they weren't focused on the clinical needs of the patient. And then the value, one of the areas, if you've ever heard me speak before, you've heard me say that value of the project needs to be, the value of the program needs to be in 3 different buckets. It needs to be in the patient bucket. There needs to be value for the provider. There needs to be value for the organization. And so if we don't have a value in each of those buckets and it's just for physician convenience, then we'll see that patients aren't really interested. Or if we're putting things together that are just for a business reason, then we'll find that physicians and patients aren't really coming. You know, it's the bill that you'll come model doesn't always work, and especially in telehealth. And there's some examples over there to the right. On the left-hand side, we do talk a lot. I don't want to spend too much on this slide because there's a lot of data here, but on the left-hand side, we do talk about sort of stage 1, stage 2, really isolated explorers. And this is the typical organization that I know some of you have worked with before, that maybe 1 or 2 physicians are actively doing telehealth. They enjoy it. They get grants themselves to put telehealth together. That's not really what we would define as a mature program. We want to see, and you may not want to go all the way to the top of this list, right? You may not want to be a center of excellence. However, you do want to strive towards an integrated strategy, a governance model that drives your program such that you can have measurable, achievable goals. And I would suggest that those measurable and achievable goals go beyond just how many visits am I doing. They need to be performance driven. And so I'm going to stop on this model and I'll just shift to the next slide. I know there'll be a lot of, there may be a lot of questions in the future, or maybe on this call, I don't know, but I just want to kind of stop for a second because I know a lot of words on the slide can be tough. One of the things that I wanted to note was that the adoption rate for telehealth, and particularly in this environment, has been fairly slow. So this is back to 2017, from 2014 to 17, but this was not, this number has not moved that much in the adoption rates. When we look at, I think the current numbers were from 2019. That we've reviewed. Although it's moving in the right direction, especially in this scenario that we have today, we can see how these types of innovative technologies can help us be able to reach more patients, increase capacity, and also in these times keep us safer. So I thought that was interesting data from, this really was HIMSS Analytics, but Definitive Healthcare took them over. Some of the things that we see driving telehealth programs are physician and care provider shortages. And we know that these care provider shortages are coming up today very, obviously, as we look at the shortage of the number of ICU beds, the number of physicians, nurses, et cetera, as we try to tackle this pandemic. But this already was in place, or already was an issue when we started to think about how could we extend and increase capacity within the healthcare space by using telehealth. So taking into consideration your own individual care providers' programs and what capacity you have available. And that's not just asking a physician, hey, do you have capacity available? This is a strategic initiative and looking at what types of patients do they see, what are their goals in terms of increasing their ability to see patients and expanding access to care and improving the care delivery model. And when you look at what they want to accomplish, nearly always you will be able to match a telehealth solution with what they're trying to accomplish. So the question of asking, do you have capacity to do telehealth, is the absolute wrong question to ask, and that won't be, you won't get very far and obviously won't have a very mature program. But if you do come at it as what they're trying to accomplish with their program, you'll find ways to improve their practice with telehealth. We know that the market is increasing at exponentially. This data is supposed to time out at 2021, but I can tell you that we have to update this like almost every year because this data is extremely volatile in terms of how much investment is made in this market, which makes it very difficult for organizations to make decisions. So from a maturity perspective, thinking about the types of technology that you're going to purchase rather than sort of being a sheep and following, the group, what you want to do is do a thorough investigation of a technology. So if you have the time and energy and effort, and I know no one does right now, but when you do take a breather, and you're able to evaluate those technologies. Some of those, obviously, the TRCs have done some of those evaluations for you. However, for yourself, you want to look at what are your criteria. What's your go, no go for technology, for example? And I'll give you a great example of this. There's a great TRC. You all service some of those folks in the New England area, and we have a client that is in Maine where they were utilizing their remote patient monitoring solution. They wanted to use a high-profile vendor, or they were included as part of the list as a high-profile vendor. However, we were not able to use them because in that area, they were only connected to AT&T. Well, AT&T didn't work in that area. So even though we could have potentially seen the organization go towards a high-profile vendor, because they took the time and were mature about selecting their technology, they actually were able to vet through and find out that there was a go, no go, rather than going down the road of contract negotiation and discussion and then finding out that this was really not a solution that was going to work for them. So this is back to the maturity model. This is a particular facility. You can see the green blocks there. This is a particular facility that we worked with and where we rated them from a maturity perspective. And I note this because typically organizations live in this 2 to 4 range. They may have a steering committee, although very often they do not. They may have a vision in which they hope to achieve. In this case, they only had some reactive, sporadic services. And then organizations may have some kind of uniform platform, or they may be looking to expand into something that is multi-use. And that's the purpose of having a unified platform. It doesn't need to be one technology, but it should be unified such that you're able to support it appropriately in the future. So if you have a bunch of different pieces of technology, it's sort of like the best of breed approach with an EMR. That can be very difficult to support long term, and we've seen how that has changed in the market in the EMR space. We're really contracting down to a few different vendors with very few external vendors outside. We're not doing best of breed in each section. What we see a lot is people that are doing store and forward. So these are very lower, isolated, explorer types of things. The organizations that we see that are excelling and moving their programs even further forward, are utilizing an evaluation strategy to determine what types of services they should use, what technologies, and then whether or not their processes are in place as well. Trying to be conscious of my time. One technique that we utilize to look at an organization and help to formulate a plan is to, go ahead.
No, I think there's just an unmuted line. That's all. Keep going, Michelle.
Oh, sorry. Okay, so one technique that we use is a SWOT analysis, and this may be familiar to you or not, I'm not sure, but those things that are at the top are internal types of issues, those that are attributes of the organization themselves, and external at the bottom. And so we categorize internal and external strengths and weaknesses, and then we're able to create an action plan from that. So often an organization may have an executive who's very passionate about the telehealth program, and that would be great to have in the strength. But on the weaknesses side, perhaps their compliance department has a lot of hesitation around telehealth, and therefore is really squeezing the juice out of the telehealth program. And so we're having to balance those two, and then we can start to tackle that list of things to be able to raise that program up. And you can see some are harmful and some are helpful. And when you look at threats and weaknesses from an external or internal perspective, some people will look at external perspective attributes as threats for competition. And that isn't always the case. Competition isn't always your threat from an external perspective. A lot of times we've seen in the past, many of the federal programs have been a threat to telehealth. Recently, we've seen that really opening up, and we're seeing a lot of improvement. Outside of the pandemic reaction, we're also seeing some improvement prior to that from the federal and state local regulatory environments as well. So you can utilize a SWOT analysis to help you to really create a task plan and allow you to be able to move forward and to move up in the maturity model. Lots of challenges that exist. This is an example of one particular organization that we worked with that had been around for quite some time. This program had been around, but they had kept it in only a couple of different lines like stroke and some cardiovascular. So lots of issues here in convincing physicians of value across the organization reimbursement. This is not atypical, this challenges list. However, sometimes we do see reimbursement not being that high on the list. They do want to do it just because they can start to see now the ability for them to increase capacity and just improve access to care and the care delivery model. This is a particular model that we use. We use all of these 4 pieces to be able to determine whether or not a particular service meets the need for the telehealth department to act on it. Does it have a clinical need? Does it meet the business goals? Does it have a community need? And does it meet our corporate priorities? And when I mean corporate priorities, like vision, mission of the organization. So I won't spend a whole lot of time on that just because I know I'm a minute over. just wanted you to know there's lots of elements here to be able to have a successful program and improve and mature your program over time, including reviewing your technology and clinical workflows and developing your performance metrics. And I'll end on a kind of a humorous note given our scenario, but either they have a virus or my computer does. Typical telehealth view. I really appreciate everybody who've invited me here today. I wish I had, an hour and a half to 2 hours. We will be doing telehealth webinars ourselves with all of the information that's coming out and updates. And I know you all will be giving some good updates on this call, but we'll be doing them as well. They're all free. We want to, just like the TRCs do, we want to make sure that everyone who wants to do telehealth can do it. So thank you again for inviting me.
Excellent. Thank you, Michelle, and thank you for placing a little bit of humor into there. If anybody has a question, please submit it through the chat box, and we'll make sure to get those asked. While we're waiting for those messages to come through, Michelle is absolutely right. There are a number of upcoming webinars that are being put on by several different organizations, which I'll just touch on briefly while we wait and see if any questions come through. So, Michelle, do you have a date and time for the webinar that Blue Cirrus is doing?
Thank you for asking. We do. We will be doing, at 12:30. Oops, I just put it up on my screen. There you go. We'll be doing it at 12:30, and we'll be reviewing probably as well some of the things you may be as well, the guidance that's coming from the House that we expect to be signed today, those things that are coming from the CDC, general recommendations for processes, et cetera. And then I'll also be doing another webinar on Friday with ATA, reviewing the uses and use cases for telehealth given the response for the pandemic. The time for that, I'll look for a moment and just make sure. Well, I'll check that right now.
Okay, and you cut out a little bit. The other webinar that you're doing at 12:30 is on what day?
It's on Wednesday.
Okay.
And I'll send you the link to that. We are also offering free sessions with our consultants. So we're offering for folks who want to do quick starts for telehealth, to do times just to pick our brain. We're finding a lot of our clients, if they even have programs today, they are asking, for example, a behavioral health, they may not have a behavioral health program, and right now we're getting asked by one of our clients to quick start on a behavioral health program. Given all that's going on, all the stressors, folks that have behavioral health visits, they're not really coming to their visits because they have apprehension, and so they want to continue to have those visits via either a virtual visit or telephonic. So those are the types of things that we're working on right now.
Excellent. Yeah, if you could send me information on that, that would be great. As much, information as possible that we can provide to people as they sort of try to figure out how best to navigate this would be appreciated. And then the information on the webinars. There's a number of webinars happening this week in addition to the two that Michelle just spoke about. The National Consortium of Telehealth Resource Centers is hosting a webinar on Wednesday at 2 o'clock on telehealth and COVID-19. I will send links to all of these webinars out with the meeting notes so you won't miss anything. And then the American Telemedicine Association is hosting 2 webinars that I know of, now 3, since Michelle mentioned another one on Friday. There's one on Tuesday at 2 p.m., so tomorrow, and that's ATA COVID-19 Update Series, Waivers, Remote Monitoring, and Telehealth. And then Wednesday at noon, they are doing another one, Telehealth for COVID-19 Across Care Settings. So there's 4 different webinars right there actually 5, with a wealth of information on how to kind of quickly start up a telehealth program or service line to see your patients. I did get 2 questions for you, Michelle. The first one's an easy one. Can we get your slides on the maturity model?
Very easy one. Yes, of course.
Okay, those will get sent out with the meeting notes. And then another question came in. We are a school of nursing working on integrating telehealth into our program. Our goal is to begin preparing nurses to use the peripheral equipment. Any suggestions on opportunities for students to be present during real encounters?
Oh, wow, that's a great one. So we happen to be working with a school of nursing right now. So it's interesting that you asked that. And how would we be able to, any ideas on opportunities for folks to be present on real encounters? Is that the question? Just want to make sure I have that fully vetted.
I don't, yes, she just responded yes.
Okay. Okay, perfect. So I think that, one of the things that the academic centers are having issues with, and that's certainly been our experience, is getting technology. So some of the vendors that are out there, so if there's any vendors on the line, we're seeing some resistance from them that they're not providing that technology to the academic centers for free. So first of all, academic centers are not actually providing visits, so we shouldn't be seeing academic centers being charged service fees, purchasing your equipment, et cetera, overall. So just as a baseline. Now that you potentially have the equipment and you need to do or want to do visits, I think a great partnership between, the healthcare provider, that local healthcare provider that's in your area, and the academic centers would be a great place to be able to bridge a gap between just being able to provide care within the healthcare facilities with the nursing programs. But now we're seeing even some nurses being called up that, may have been retired, et cetera. So you may be able to have some what do we call that? We'll call it a shoulder to shoulder, sort of visit, where we have in the same way you would in a regular physician visit, where you've got a physician having a visit with a patient, and you might have a resident in the room. They may tell you, hey, I'm bringing a resident around. The same thing can be true with a telehealth visit. Anything, this is what I tell my team, regardless of what we're doing, anything that you would normally do face-to-face, you just have to bridge that gap from a technology perspective. So if you would normally talk to somebody, pick up the phone. If you would normally look at something, show it in a video visit. So I think there's possibilities there to be able to have nursing students kind of on the shoulder of folks that are there taking care of those patients. And maybe even now more than ever, they need to do that, because we hopefully will never have this situation again. So we want to have trained nurses to be able to provide that care should this ever happen in our lifetime or the next.
Excellent, thank you. I haven't seen any other questions come through. So Michelle, thank you for your time today and for providing this information. Her slides will be sent out with the meeting notes, and I will include Michelle's contact information.
You're welcome, and thanks for having me. My webinar with ATA is on Friday, March 20th at 1 p.m.
Excellent, thank you. All right, so moving on to the next part of the agenda, I'm going to switch roles over to Katie Oram. And Katie is the Geriatrics and Palliative Care Program Manager for the eMOLST administration for New York State. She's going to provide an overview of eMOLST as a telehealth opportunity focused on advanced care planning, end-of-life care, and palliative care. So Katie, go ahead.
Thank you so much, Katie. So I run the eMOLST system for New York, and eMOLST is the electronic version of MOLST, and certainly MOLST is integral to advanced care planning for our most seriously ill New Yorkers. So eMOLST is both the electronic form and the process for completing the form. It's a tool to complete the electronic form, and it also serves as a registry for MOLST orders from across our state. It incorporates both the MOLST form that many of you are familiar with from the health department, as well as all documentation, including the OPWDD checklist where it is required. So we also have the capability with eMOLST to incorporate paper forms from primary care, SNF, even hospice settings to help organizations get started with the tool. As we know, many of you have been using paper MOLST for many years. And then eMOLST, on a go-forward basis, guides clinicians and patients through that thoughtful discussion and process, including all the legal and ethical requirements that today your clinicians may be capturing or not capturing freehand in your charts. So eMOLST ensures that that MOLST process is completed correctly, and then of course the orders are always accessible 24/7. Certainly in the state of emergency that we're in today, we've had a number of inquiries from hospitals looking to gain additional access to eMOLST to be able to retrieve existing patients' medical orders. With the eMOLST system, you can always print a copy for the patient on bright pink paper for any paper workflows necessary. You know, we've heard from our EMS colleagues that, you know, electronic is great, they certainly want access to it, but there's also no substitute to having that printed MOLST form right in front of them, you know, on the fridge or on the nightstand in the patient's home in an emergency. And then eMOLST is accessible 24/7 at the URL on this slide, but it also can be integrated with an EMR or used in a hybrid system with single sign-on and API available. So here are some definitions. You know, when we're talking about eMOLST, the form refers to both the MOLST form and the documentation forms that accompany the MOLST. And many of you might be familiar with the documentation forms. They come from the New York State Department of Health checklist or the OPWDD checklist. And, you know, while those tools are not required to be used in our state, you're always welcome to document freehand in the chart. We know realistically it's hard to keep track of the multiple different public health laws that intersect when it comes to withholding and withdrawing life-sustaining treatment, and that the chart documentation forms modeled on the DOH checklist are the best tool available. And so eMOLST will generate those forms for you. It also allows organizations to eliminate a number of their own facility forms related to this process because they know everything is kept in one place. And because eMOLST is serving as the registry for the state, your organization is able to see exactly where another organization left off with a particular patient, whether they've gotten through the conversation about resuscitation and intubation only, for example, but hadn't been able to yet address feeding tubes, IV fluids, hospitalization, those other items. So eMOLST will produce both the MOLST form and the chart documentation form that aligns with the appropriate DOH or OPWDD checklist based on who the patient is, who the decision maker is, and where that decision is occurring. Many of you may be familiar with New York State public health law that varies by setting when it comes to withholding and withdrawing life-sustaining treatment. The rules are different in hospitals versus nursing homes versus hospice versus outpatient settings, and eMOLST has all of that logic built into it. And then from a value-based accountable care perspective, eMOLST improves quality, patient safety, honors patient preferences, and then can help reduce unnecessary or unwanted hospitalizations, ED use. Because of the care plan that needs to accompany these MOLST orders, certainly you can't, just send grandma home with a MOLST and expect it, to magically all work. We still need to do that care planning to ensure that her preference for hospitalization, for example, can be honored in the community and that she has the right community-based resources in her home or available to her telephonically or virtually so that her preferences can be honored. So when it comes to payment, of course, I work for Excellus Blue Cross Blue Shield, which has supported the MOLST program from its inception in New York State. And I'm happy to spend a moment talking about payment. There are two codes to bill with advanced care planning discussions. And I can tell you that eMOLST meets the requirements for billing these codes. They're 99497 and 99498. 99497 for the first 30 minutes and 99498 for each additional 30 minutes. Even a quick look in our own service area has told us that these codes are being underused. We know that providers are having these conversations, certainly in all settings, and these codes can be billed in all settings. But for the volume of conversations that need to be occurring, we know these codes are being underused today. We have a separate webinar for billing with a URL there that you're welcome to share. The codes can be billed with other E&M, TCM, and CCM codes. So it's, as well as during the surgical period and in critical care. There are no site of service limitations to them. I can tell you our health plan covers these codes for all lines of service, and that certainly Medicare and Medicaid cover them universally, as CMS adopted these codes in 2016. However, for commercial carriers, you need to check with each one to see how they are covered. In terms of RVUs, the first code is worth 2.4, and the second code, I believe, is worth 2.09. So these conversations may take time. Certainly they will take time. They need to be done in a patient-centered way and in an ethical way that complies with New York's legal requirements. And eMOLST is a tool to help your team do that effectively. Certainly we provide a variety of MOLST education to accompany eMOLST implementation as well. And I will close with a case from 2014. This case is from the North Country, Alex Bay area. This gentleman's primary care physician had completed an eMOLST for him. He had multiple medical problems. He was age 83. He had COPD. He had one lung out due to lung cancer and recurrent hospitalizations with acute respiratory problems. He had a healthcare proxy, and he completed that MOLST form in eMOLST with his physician, or rather his physician completed it in eMOLST. As these are medical orders, they can only be completed by licensed physicians and nurse practitioners in our state at this time. June 17th, 2020, PAs will be added based on a legal change that went into effect, that's going into effect this year. But this gentleman presented to the emergency department at in Alex Bay at River Hospital with acute respiratory insufficiency. He was with his 80-year-old wife, who couldn't put two words together in this emergency, and certainly couldn't communicate, oh, we did that pink form, this is what it says. The ED physician, Dr. Alfredo Torres, took one look at this guy and said, wow, if anybody needs a MOLST, it's this guy. And I really don't want to intubate him and ship him 100 miles south to SUNY Upstate. So he checked eMOLST, and fortunately his orders were there. The original plan was, of course, to intubate him and transfer him down south to SUNY Upstate over 100 miles. Instead, they followed the eMOLST orders, which were for conservative treatment, focus on functionality. The man survived that admission, and he was discharged home, where he died 2 months later on hospice. So, you know, obviously that was eMOLST being honored in an emergency, and, you know, outside of having those orders accessible 24/7, it would have been a very different outcome for this gentleman and his family. Are there questions about eMOLST?
Nothing has come in. We'll just give it another minute to see. Katie, will you be able to share those slides with me so I can share them with the group?
Absolutely. And this is like a section of my normal slide deck, obviously, condensed for this group and really focused on some high-level stuff related to eMOLST. I'm going to send you the full deck so that you have the other MOLST elements included too.
Excellent. No questions have come in, but if they do, we'll pause to answer them. So thank you so much, Katie.
Of course. Thank you so much for having me.
All right, everyone. So I am going to talk about some COVID-19 telehealth updates. Don't feel the need to feverishly write down any of this information, as we are working on putting together a resource document. And granted, there are a lot of different resources out there. We're trying to just compile everything that is pertinent to all of your different agency types into one document. And we're hoping to have that out by tomorrow morning at the latest. So updates have been coming in literally by the hour. And what we know so far from the New York State Department of Health is that effective on or after March 13th, during the current state of emergency only, New York State Medicaid will reimburse telephonic evaluation and management services to members in cases where face-to-face visits may not be recommended. So these telephone E&M services must be provided by a physician, nurse practitioner, physician assistant, or licensed midwife actively enrolled in fee-for-service Medicaid or Medicaid managed care plans. Relevant CPT codes will be 99441, 99442, and 99443. I will be sending out the actual memo from DOH with those codes, what they mean, and the reimbursement rates that they carry. If you have questions, you have two options. DOH has a line that is available to answer questions. It's 518-473-2160, and I'm going to type that in the chat box real quick so you guys have it. I was advised by Megan Procrum earlier, though, that line is getting very overwhelmed. So what she recommended was, if you have questions, send them to me, and between Megan and I, we'll kind of batch like questions, and she will get back to you as soon as possible. It's my understanding that everyone at the state is working very hard on trying to get back to folks in the wake of this pandemic. So that's the DOH update. For OMH, OMH came out last week with some telemental health guidance, and then I found out this morning that effective March 13th, telemental health for Medicaid reimbursable services was expanded to telephone or video, including technology commonly available on smartphones and other devices. The telemental health practitioner can include any professional, paraprofessional, or unlicensed behavioral health staff who deliver a qualified service via telemental health. Providers may deliver any service appropriate for individuals to receive via telemental health, including individual, group, and collateral services, clinic integrated outpatient services, and clinic-based intensive outpatient program services. Providers do need to fill out a self-attestation form that is required, and it needs to be completed and sent to Amy Smith. Her email is amy.smith@omh.ny.gov, and I'm putting that in the chat box as well, but again, this will be in the meeting notes. OASAS is following suit. They recently issued a telepractice waiver and updated it as of this morning to clarify that during the duration of the declared disaster emergency, telephonic delivery is an acceptable means of service delivery for telepractice by OASAS programs. Providers should bill for telepractice services exactly the way they would bill for a service provided by other means, with the only addition being the modifier for each type of service. Following suit with OMH, you do need to, complete an attestation form, and that attestation form needs to be completed and submitted to certification@oasas.ny.gov. I just put that email in the chat box. This self-attestation will permit providers to deliver services via telepractice for a time-limited period, not to exceed the disaster emergency. Services can be delivered to any patient admitted or seeking admission to a program. So moving on to Medicare. I sent out an email last week with some changes to Medicare, as there were bills passed, HB and HR 6074. So refer to that email, which I will again include those links in the meeting notes and the subsequent resource document. But the Center for Connected Health Policy came out with a great summary of that bill and some of the restrictions, geographically speaking, that are being waived. Additionally, the Trump administration did issue guidance to allow Medicare Advantage and Part D plans to waive the cost sharing associated with coronavirus testing. CMS released a moratorium, which I will send out with the meeting notes, highlighting plan sponsors' options to ease cost barriers associated with the spread of COVID-19. Medicare Advantage and Part D plans can waive members' cost sharing for tests or visits to doctor's offices, emergency departments, or via telehealth. Medicare Advantage and Part D plans also have the option to nix prior authorization requirements, waive limits on prescription refills, and ease restrictions to home prescription delivery in order to grow access for telehealth. So lots happening in both the state and federal space. So from the commercial payer side, our regional North Country payers seem to have similar verbiage on all their sites. They're all covering office visits and COVID-19 testing at allowed facilities. We have read online that the State Department of Financial Services is ordering insurers to waive copays for telemedicine. I was unable to confirm if that's accurate. So, if that is inaccurate, please send me a chat or an email. There are some payers such as Excelis are putting out verbiage. A telehealth visit is also an option to do initial screenings, and telehealth services are covered under all product lines. The member is still responsible for any copayment or coinsurance for a telehealth visit. Members with high deductible health plans are responsible for the entire cost of the deductible has not yet been met. Other regional payers don't necessarily mention telehealth other than urging members to use their direct-to-consumer platform for care. We are going to send out a link. It's from AHIP, and it's a health insurance provider's response to COVID-19. It lists out many large national insurers and the steps they are taking to help during the pandemic. And then lastly, we already talked about the webinars that are coming up, but there are numerous software resources, telehealth software resources that are offering free trials or free licenses. So I wanted to make you all aware of what options you might have. So if you're looking for telehealth software that's HIPAA compliant, we found a couple of options. The first one is CloudMD. They are offering free trials across North America to help manage coronavirus. We will be sending links to all of these websites directly to where you need to go to access more information. VidIO is offering free temporary licenses. VC is working with providers to set up an online virtual clinic, and it does include a BAA for HIPAA compliance. Bluestream is providing a free HIPAA compliant virtual care solution to help care providers work with patients that are impacted by the COVID-19 outbreak. Cloudbreak Health is offering a free app. And then Perinatal Access is a virtual health platform that helps expectant mothers with high-risk pregnancies get the help they need without the need to travel to a specialist office. Due to the COVID-19 outbreak, Perinatal Access is offering 60 days of access to the platform at no cost, and I will send out the link with more information on that. So that is what we have right now. I am going to just check in with my colleague, Bob Hunt, if he has any updates for the group. Bob, your line's unmuted.
No updates right now. Thank you.
Okay, excellent. So again, stay tuned for a resource document and meeting notes with links and PDFs with all of the forms and information that I just shared with all of you. I know that it's changing by the hour. Our telehealth team is trying our best to stay on top of it. Don't hesitate to send us an email with your questions. If you're unsure what to do, where to reach out to, we can point you in the right direction. I am putting my email in the chat box right now, as well as Bob's, and we can certainly help you during this time. It's important that we support each other and make sure that we are staying safe practicing social distancing and, working through this together. We're here for you. So of course, don't hesitate to reach out, and thank you for joining our learning collaborative. Our next one is going to be in May. It is planned for Monday, May 18th at the same time from 2 to 3 p.m. More information will come out as we get closer to it. So again, thank you. Have a wonderful day.